My name is Megan Phillip, and I have the incredible privilege of serving as the Executive Director of HC3, the Healthcare Council of Chicago, which is a thought leadership and networking platform powered by Chicago-based organizations that are committed to driving meaningful change, improving health outcomes, and tackling the challenges that impact our communities. We are proudly managed as an initiative of Third Horizon, a boutique advisory firm shaping the future of healthcare both locally and nationally. Today, we gather at a defining moment in the United States healthcare ecosystem. This past year has brought on some of the most rapid and disruptive shifts we've seen, reshaping how healthcare is delivered, financed, and experienced. So our conversations today will begin with a fireside discussion featuring David Johnson, CEO of Foresight Health and author of The Coming Healthcare Revolution. We are excited to welcome Dave back 1 year later after the release of his book to reflect on how predictions are unfolding in the market. Following the fireside chat, we will be joined by a panel of experts. Incidentally, all of them are practicing physicians who bring their firsthand perspectives as leaders navigating these changes as we see and feel them in real time. So they will offer their insights and innovation around these financial pressures, policy currents, and market forces as we continue to reshape the future of care. So together, we're going to explore not only the challenges, but the strategic opportunities ahead. So without further ado, I am delighted to turn things over to our moderator for today's program, someone who I've known for quite some time in my short but long career and whose opinions and experts I truly value. Please welcome Lynn Hennessian, founder and chief engager of the Engager Company, a healthcare communications and advisory partner that helps organizations thrive in today's complex and fast-evolving health ecosystem, as well as our featured guest, keynote speaker, author, podcast host, strategic advisor, and healthcare revolutionary, David Johnson. Let's give him a round.
It's good to know my microphone works.
Well, I'm delighted to be here. I was introduced on Monday at a panel on health equity as the chief instigator, so I'm looking forward to do the same thing here because we have a lot of urgency around getting healthcare right, and we have made not enough progress in doing that. So I'm delighted to be here to be the moderator of a tremendous panel that has strong expertise, background, and opinions and insights on where we're headed. And we're going to start with Dave and sort of setting the stage a little bit. And conveniently, I'm going to just say this because the title of it I think is brilliant: Reset or Reinvention, the State of the System. And as those of you who are regular, frequent attendees at HC3 events, he had a book last year that was talking about, I don't know, maybe revolution, maybe transformation. And in 1 year, he's felt the need to update it because the pace of change, the urgency, the pressures in the marketplace have changed quite dramatically. So I'm going to ask you, Dave, what a difference a year makes. Give us a little bit of a high point, highlights, and deep dive.
Yeah. So Paul Kusserow and I co-wrote The Coming Revolution, and it published almost exactly a year ago. It was the end of November. It was a megatrends book, and our thesis was 10 forces, 5 macroeconomic forces pressing down on the largest industry ever created by human beings and starting to crack it. And those 5 forces, they aren't hard to identify. Demographics, funding fatigue, chronic disease, explosion of chronic disease. We called it chronic pandemics. The only one galvanizing force is technology. We're, in my opinion, living through not one but 2 earth-shaking technologies that are feeding off one another. AI, which everybody talks about, but synthetic biology, the other one. And it's interesting. Everybody knows you can't do synthetic biology without the massive data sets and the pattern recognition and so on. But what's really interesting when you look at AI is how biological the systems have become to replicate, neural networks going viral, all of that. So they're going together. And then the last one was pro-market reforms. And we're seeing under the Trump administration a lot of emphasis on that within CMS. So any one of those forces is powerful. The five together are irresistible. And you start thinking about compounding effects. And this industry's been remarkably resistant to change. So our punchline, again, a year ago, was more change in the next 10 years than the last 100 years. And that 100 years wasn't a throwaway comment. Medicine came of age in the early 1900s. It went from a very underappreciated profession to one that achieved enormous status. Our model for medical school came of age sort of the teens and the 20s, based on Johns Hopkins. It's still largely the same today. 4 years of college, 4 years of medical school, first 2 years are science, rotations, residency, fellowships. And that model propelled the United States to leadership in the world. It rested on science, the double-blind studies and so on. But it was very hospital-centric, disease-centric, physician-centric approach to care. And then we've had, obviously, many things going on, but probably the most prominent is the explosion of chronic disease, which occurs over a lifetime. It's not episodic. So the model really hasn't changed that much, and our belief is you not only have the largest industry ever created by human beings, I mean, it's bigger than either the economy of Japan and Germany, which are the third and fourth largest in the world. So you got, U.S., China, U.S. healthcare, Germany. It's also the world's largest industrial complex. And Eisenhower was the one who warned us about the military-industrial complex in his farewell address, where he said the conjunction of industry, bureaucracy, and Congress work for their own interest, that conjunction end up working for their own interest at the expense of greater society. And when he warned about that, he used words like grave peril in every city that is economic, political, and spiritual. Economic, political, and spiritual. Industrial, and we all know what industrial complexes are like today. So in 1960, when Eisenhower gave the speech, military, believe it or not, was 9% of the economy. Healthcare was 5%. And today, military's 3%. And we have a military-industrial complex in case anybody hasn't seen the $8,000 toilet. But by comparison, the healthcare industrial complex is orders of magnitude greater. And it's not only at the federal level, it's at the local and state levels. And this conjunction of industry, our political system, and then the various bureaucracies and all that goes back and forth really are working for their collective interests at the expense of greater society. That's our point. So that's why it's been so hard to crack. And I'll speed this up because but anyway, the other.
You sense the microphone coming to my mouth.
Yeah, well, actually, what I sensed was it hitting my head for a second. But the other.
That would create a healthcare need. That's not what we're here for, Dave.
The other half was the market forces coming up from the bottom, and I won't get into those specifically, but markets hate a void, and as the system cracks, we're getting more and more companies that are betting on consumerism and value starting to fill that crack. So why do I think that the pace is accelerating? In fact, today, if we were writing the book, I think Paul and I would say more change in the next 5 years than the last 100 years. And I'm going to isolate on 3 things. And Lynn was just at the Forbes conference. We were both at it last year, didn't know it. And it was the day Brian Thompson got murdered. One of the strangest days of my life, because the Forbes conference in New York, it's about 1.5 miles from the murder site. And the announcement of his shooting and then death was occurring in real time during the conference. And what struck me, still strikes me, was how Brian Thompson, by all accounts, a very decent individual, went from villain or victim to villain in a nanosecond, and how the social media turned on the industry. So we've got consumers raging at the machine. I would say the development of AI is, we saw it coming, but it's coming even faster, and everything that portends. And then the last one is the Trump administration, particularly through CMS, just moving fast and breaking things, cutting funding, going after things that historically have propped up an unsustainable system. And so all of that, you put all that together, and our macro forces get harder, it creates more opportunity for the bottom coming up.
Yeah, so I just want to add one little itty-bitty data point. So I spent 25 years studying...
Itty-bitty? Is it
Itty-bitty.
itty-bitty?
It's itty-bitty.
Okay.
Study trust. I worked for Edelman Global Healthcare Company, and one of
Trust index.
the trust index. So one of the things that was really interesting is in last fall, when the Brian Thompson was murdered, we had just debuted in January the study. Well, the data had been gathered around the presidential election, and I've always tracked, do you trust healthcare? Do you trust pharmaceuticals? Do you trust payers? And they had always lagged in the middle or the low because people just didn't care because it was just fine. And then when the pandemic started, all of a sudden, healthcare and food and beverage went to the top 2 trusted industries. So, 5 years out from the pandemic, I was thinking, well, what really happened in healthcare? So I dug in, and the global numbers were largely unchanged. In the U.S. last fall, going into the election, trust in healthcare in the U.S., according to the Edelman survey, went up by 10 points. 10 points. It had not gone that high and that fast since the beginning of the pandemic. And I believe that part of it is, and now since reflected, people's anxieties were high. They're concerned about their families. They're concerned about their communities. And they're worried about losing access to care. And I think that, as we saw in the government shutdown, shows that you have huge public forces that then can be translated into political forces. But also, my great concern is we're going to end up with the haves and have-nots. And we know that trust divides on that index. So while we go through this revolution and we see optimistic voices that we're going to see this change in 5 years, what do we need to be looking for to speed transformation for everyone, as opposed to a bifurcated, just the 12 billionaires who run this economy and this government?
Yeah. The 64, it's not even, okay, the $6.4 trillion question. So I'm going to tell you why I'm optimistic about...
people have to feel good after this. We all came in worried to death.
Right. So I've been, the last book was my third book on the sort of the healthcare system, and I'm a markets. First one was market versus medicine, and then the customer revolution, now the coming revolution. And so I've been on this revolution theme for quite a while. Breaking news, we're going to change our logo and our tagline. Our tagline's expect better healthcare, which goes very well with revolution, to build better healthcare. And one of the where there is hope, ironically, is in the inefficiency of the current system. So everyone knows we spend twice as much per capita as every other advanced country, and our people live 6 years longer. And it's even worse because people like us in this room will live to our mid-80s on average. And you go to the south and west side here, and the what they call the death gap is not only in double digits, well into the 20s, and between Bronzeville and Streeterville is 30 years. I mean, just think about that. So why, when things are breaking apart, which they are, I mean, the safety net in Chicago right now is on fumes. And the reason I believe to be hopeful is incremental solutions cannot solve exponential problems. It's funny, I spent the first 2 days of this week at Harvard Medical School in something called the Industry Working Group and getting preview of studies. And there's a reason they call economics the dismal science. Oh my God, how you get an accurate data set. But microeconomists, economists by general, are always looking at the margin. How do we marginally improve what's going to happen? So what needs to happen in the country, and it's really pretty simple, is we need to spend more on pro-health activities, prevention, promotion, chronic disease management, behavioral health, so that we can spend less on acute care. So we need a massive transfer from spending on treatment to spending on prevention. And I believe that's really starting to happen. I mean, on the tech side, you've got several companies now where you can get a blood test and they will tell you your susceptibility to over 50 types of cancer. We seem to be almost on the cusp of being able to tell people 4 or 5 years in advance whether they're going to have Alzheimer's or not. So imagine a world where we can diagnose disease much earlier and the interventions are much better, and it costs a huge amount less. The question's really going to be, what do we do with this massive investment that we've made in the acute care side of things? And I said I was in the Longwood area of Boston. The billions of dollars spent at, on those campuses between the medical school and the Children's Hospital and Dana-Farber and Brigham and so on. And that more of that kind of investment isn't going to make us a healthier, more productive, more equitable nation. In fact, on our continued path, all of those things get worse. We spend more and more money on chronic disease, and we're less equal, we're less productive, we're less happy. And who wants that for the future of the United States of America?
So you mentioned I was at Forbes Healthcare Summit last week, and we've got people who are now focusing more on whole health. One of the trends that you note in your book. The other is sort of a focus on longevity. And interestingly enough, we've got 4 things that we know that will help us live longer. And the question is, how much of this is the bailiwick of our healthcare sector and industry versus society, right? So everybody can speak along with me. Nutrition, exercise, sleep, and community socialization, right? So how many of those things happen outside of it? And we've seen a lot of health systems step into areas where they understand, for example, at UI Health down here, when they recognize if we could put roofs over the heads of some of our unhoused, frequent ED visitors, we can improve their health and reduce their healthcare costs, right? By putting a roof over the head. So I do think we need to have a conversation regarding society's role in all of this. But again, other than the fact that we're going to run out of money and we're an aging population, is technology going to be enough? And how much do we shake up, as you say, Healthcare Inc., the big forces right now that sit, Brian Thompson's business, many others, uniquely large versus other countries?
Well, I'm a student of disruption, and many of these businesses need to go away. We'll start there. But I wanted to talk a little bit about UIC doing housing. Seems very noble on the surface, and it is. Comes from a good place. But competing on health care, as your point makes very clear, is very different than competing on health. And I would argue our healthcare system isn't even doing a great job of what it should be doing. Right care, right time, right place, right price. Needs to decentralize, it needs to get much more efficient, it needs to become more digital into the home, all of those things. And to expect an industry that really isn't good about what it's supposed to be doing to simultaneously address social determinants, or what I call health multipliers, is like the dumbest thing I've ever heard of. I'll tell you a funny story, a little inside baseball. So right before COVID, I was at a conference in New York, and Politico had just come out with a hatchet job on academic medical centers. Dan Diamond, who's now at the Post, wrote it, and it was basically academic medical centers are doing great under Obamacare, but their neighborhoods are deteriorating around them. And the implicit bias was it's not enough to push back the frontiers of research, train the next generation of doctors, and provide cutting-edge clinical care. We need these institutions to be involved in empowerment, neighborhood development, all of those kinds of things. And I happened to be with Toby Cosgrove, who was just leaving Cleveland Clinic at the time. And not only did Diamond do that general article, he did a deep dive specifically on Cleveland. And so Toby had a couple of drinks at this point, and anybody knows him gets pretty voluble after a couple of drinks. And, hey, what did you think of that Politico article, Toby? Egging him on. And expletive this and expletive, I don't know, and he was a great leader at the Cleveland Clinic, still a great leader in healthcare. And, I kind of looked at him and I said, Toby, nobody ever writes these articles about HCA. Cleveland Clinic's not really great at doing all this social development stuff. Why don't you just pay your taxes and let other people worry about all the things they're accusing you of not doing? And honest to God, it was clear nobody had ever asked him that question before, because it got uncomfortable. I don't know how long it was, 45 seconds, a minute. He's kind of looking at me, and I could tell he was trying to figure out what to say. And finally he said, Dave, I tried something like that a dozen years ago, and they shut me down. And then he changed the subject as quickly as he can. But it kind of gets to this point, healthcare is maybe responsible for 20% of health status, and you got all this other 80%. And why should we expect the system, which we're already overfunding and really needs to reinvent itself, to address these larger societal problems? And I just don't think we should. So have them pay taxes. That would be mine.
Okay, so we have just one more comment sort of before we bring our panelists up. Okay. And if you want to say something that's threatening to physicians, now's the time, because two are about to join you, and we'll reclaim the authority very quickly. My question to you is, we're in our current environment, current administration, and as you say, CMS cutting. Are we thinking that by starving the system, it's going to unleash innovation, or how do you get big changes to happen without a revolution that has a potential substantial negative impact on the uprising combatants?
Yeah. So, and I will address your physician question here in a second. But when I started Foresight in 2014, and I'd been a healthcare investment banker to large health systems, and I'm almost ashamed to admit how successful I was at doing that. Over $30 billion of bonds to build way too many hospitals and ambulatory centers. I put together some of the large systems and so on. And by 2014, I just couldn't do it anymore. I felt that I was contributing to the overbuilding of the acute care footprint in the country. And then the question was what to do next. And who knew it? It turned out I wanted to be a writer. Didn't know it at the time. But at the time, then, my critique of the industry hasn't changed at all. I mean, I'm saying more change in the last 100 years or 10 years, or next 10 years than the last 100. And in fact, in the book, we found an article from Fortune magazine, January of 1970, where the letter from the editor could be read verbatim today as long as you change the word manpower to personnel. So we've known what's been wrong for a very long time. So the critique hasn't changed, but I thought the industry had a shot at reforming inside out. Obamacare was new. We had all the new payment models, leaders saying the right things, but fast forward to today, and it's worse than ever. We're still far more dominant with fee-for-service medicine. We're getting greater spreads between the haves and the have-nots. Chronic disease has been exploding. It's recovered, but we lost life expectancy in 4 out of 5 years, I think, up until 2 years ago. Now it's started to come back up a little, but we like that. So I believe, and that's why we wrote the Megatrends book, that the change that's coming is going to be more outside in than inside out, and it's going to be messy. I happen to think we're so inefficient as an industry that by redirecting funding away from the high-cost, centralized, physician-centric delivery model will free up enormous funds, not only to invest in social determinants, but to pay people more money, to invest in more productive industries, to fund vital societal needs. But I struggle with the question of what do we do with doctors, and particularly specialists. So 2 years ago, I spent an afternoon at the Simulation Center at Mayo. And Mayo, from its founding, has believed that surgeons shouldn't practice on human beings. So they had a farm for a long time, poor animals, but that's and today, just more investment in simulation. It's really impressive. But, you can tell I'm a pain in the ass, right? So each time I went to a new station, I was sawing bones, threading catheters, suturing with a Da Vinci machine, those kinds of things. And I was just struck by how routine and mechanical these tasks were. And so at each station, I said, why do we need doctors to do this? And the answer always was, in case something goes wrong. Well, that's a dumb answer. First of all, almost nothing ever does go wrong. And when it does, you can have fail-safe mechanisms in place. We already do this for anesthesiology. So I'm pretty good friends with Zeke Emanuel, and I was thinking about writing a piece about this whole turning very talented people basically into mechanics. And I said, and he goes, am I wrong? And I said, am I wrong about this? And he goes, have I ever told you about Mozambique? He goes, no, you're right. Have I ever told you about Mozambique? I said, Zeke, you never told me about Mozambique. So at the time, Mozambique had the highest incidence of AIDS transmission in the world, and the USAID, which no longer exists, but funded a massive circumcision program. And it turns out when you circumcise males, ages 13 to 20, you virtually eliminate AIDS transmission. So Zeke goes over to Mozambique with the Minister of Health, and he's touring some of these centers that aid is funding, and they're massive. Open fields, tents, and lines of boys and young men waiting, for their procedure. And Zeke asked the Minister of Health, where did you get all the healthcare professionals to do this? 'Cause massive undertaking. And the answer was, well, we have a lot of seamstresses in this country. They're really good at cutting and sewing. 2 weeks of training, snip, zip, so. So I wrote a piece, and I had to wear a bulletproof vest for a while afterward, where it was called Circumcising Physicians, the Case for Surgical Mechanics. And I don't want to brag, but I was reasonably good at threading a catheter after 15 minutes. I mean, take somebody with real hand-eye coordination. But it takes 14 years to get certified to do catheterization. You probably need the equivalent of an electrician's certificate to do it. So we take really smart, highly talented people, and we push them into these. So that's got to stop. I mean, we got to get much more balance between sort of the training and resources needed relative to the task. But we also need to really improve our training of the front end, like Bobby's going to talk about. We just need to do a much better job on primary care, disease present, all of the things that will help create healthier, more productive, happier communities. So I don't think this happens without fundamentally changing how doctors practice in the world. It'd be an interesting conversation to get in with Bobby and Tom, and I guess we're going to. But yeah, so it's just like that Einstein saying, right? Doing the same thing over and over again the same way is the definition of insanity. What we're doing doesn't work. Incremental solutions don't work. So we need to think about exponential solutions, revolution versus evolution. That's how I got to revolution. And it's going to be messy and it's going to look a lot different. But after we get through it, I think the American people will be better off, and we will be more equitable because we don't need to spend what we're spending, which frees up a lot of money to invest in the types of things I think you'd advocate.
Do you get your care at an academic medical center, Dave?
Well, I'm One Medical for most of my stuff.
There we go.
But yeah, I mean, yeah, and I overpay for it like everybody else, and the service largely sucks.
Right.
And I honestly believe that the companies that are going to win, and we're starting to see actually some of the systems do this, are the ones that focus on end user experience. I mean, your career, and value. That word that everybody hates and defines in a million different ways, but in healthcare it means a better outcome at a lower cost with better customer experience. It's not complicated.
Yeah, and while you people may dog on economists, scarce resources sometimes lead to solutions. And so I do think that, and I know 25 years ago, 30 years ago, when I was at the American Academy of Pediatrics, we talked about the future of pediatrics, and there was going to be all this shortage, and there's a tremendous shortage now. Maybe we can find some solutions in those shortages that lead to efficiencies and cost savings. Interestingly enough, fun fact, if you have a colonoscopy in Europe, it's done by a technologist. It is not done by a doctor. In the US, it's done by a GI. Johns Hopkins did a study where they had nurses doing GIs and colonoscopies, and the findings were really great, good outcomes versus GIs, and then everybody was outraged that we were giving a lower quality of care to the people who live in the community around Johns Hopkins as opposed to the people who fly in for their specialty care. So it's going to require all of us to be open-minded and look for metrics to guide us.
So fun fact about Johns Hopkins.
Oh, I saw you say fun fact about your last colonoscopy. But Johns Hopkins, yeah.
No, the stuff still sucks to drink, right? No, the fun fact about Johns Hopkins, they have two 800 numbers, or what used to be called 800 numbers. If you're from outside of Maryland, you go into one number, and if you're from Maryland, you go into another one because Maryland's got cost controls on the state expenditure.
So I'm going to invite our two additional panelists to come up. And I don't know, we talked about whether or not we would have Q&A. If anyone has an urgent question for Dave and you want to raise your hand and ask it while we bring up two more chairs and our fine participant, three more panelists, even better. Oh, fantastic. Thank you.
No questions? Good. I must not have said anything controversial.
Oh, we have a question.
Okay.
Hi, thank you. My name is Rachel Reichland. I'm with Health Justice Partners. I'm a nurse and have worked in a variety of different spaces where healthcare is provided. And one of the questions I have for you is around funding public health. You talked a lot about prevention and moving upstream. You talked about social determinants of health. Yeah. Given that public health is largely invisible until there's a crisis, what's your solution or recommendation for investing in public health?
You know, I've got a very good friend, Michelle Williams, who's the former dean at the School of Public Health at Harvard. She's now at Stanford. She's got a book coming out that I've read and given an excerpt for, or endorsement of, called The Cure for Everything. And it's a tribute to public health historically and going forward. So it's everything all at once more. We as a country need to pivot. And you could probably boil down, Rachel, what I believe into the just simple statement that we need to invest more in health, so population health, public health, so that we can spend less on treatment. That's so. Somebody needs to. Our leaders need to embrace. And Tom will get into this in his comments because he lived through it on the South Side during COVID. We need to own public health, population health, and sing its virtues. And it's just one of the most ironic things to me is that every time we invest in pro-health activities, we generate a return for society, a pretty substantial return. And everybody acknowledges we need to invest more in social determinants of health, but providers don't do it because when they invest in pro-health activities, they lose volume and they lose money. And payers don't do it because when they invest in pro-health activities, their rates go up, members switch plans, and so on. So everybody says we need to do this. When we do it, we get the kind of results that we want. So part of what needs to happen is we need payment models and metrics to reflect what we want society to achieve. And it's just unrealistic to expect these institutions to make the types of investments you're talking about when we're not paying them to do. You know, it's that great quote from Upton Sinclair when he was running for governor in California and got licked. He said, you know, it's really hard to get somebody to understand something when you're paying them not to understand it. And we're paying large numbers of very smart people to be stupid is my opinions.
I would say, be inspired by the APAC countries. When you acknowledge that a healthy population is a healthy economy, then you recognize why it's in everybody's interest. But in the short term, we have to acknowledge that our own public health institutions, globally recognized, are being rebuilt from the inside right now. And so we need to think about how we use information and other people who recognize that they're stakeholders in population outcomes, better health outcomes, to take ownership of some of those things too. Not to go to the old Chicago models where we built communities around our institutions so we could trap our workers and pay rent to us, but we're not making railroads anymore here in Chicago.
You really do walk that fine line between cynicism and skepticism.
I don't know, instigator. So I'm going to welcome our three incredible physicians to the panel. And here's the thing. We're going to pass microphones back and forth, and someone at my last event said, oh my God, it's an infectious disease problem, so hopefully everybody's not going to pass viruses along. I'm going to ask each of our physicians, starting with Dr. Bobby, to make a brief introduction, and then we're going to open it up for conversation, and hopefully I'll instigate with just one question, and a free-for-all will happen after that. So, Dr. Bobby.
Sounds great. Good morning. It's amazing to be here just from the last half an hour of the conversation that I heard. I got David's book, and I made it through the introduction at the very beginning, and I knew this was going to be an awesome opportunity for me, not just to answer questions, but to listen when I read about the role of a Buddhist mentality, right? Something I totally wasn't expecting in the introduction of this book, to the Flexner report that sort of changed the way we do medical education, and now the role of the American Medical Association to sort of reinvent medical education, to change med ed. But I'm Bobby Mukamal. I'm an ear, nose, and throat doc in Flint, Michigan. And I share the office with an OBGYN, which sounds completely weird, but we're married, and that's how that makes sense. But then the son of immigrant physicians. My parents moved here from India, and I was raised in Flint, Michigan, and that's where I continue to practice, and just an individual practice. And a lot to comment on about institution-based care versus community-based care, the economics of that, the impact of that. But as I read the introduction to that book, almost everything sort of was like, I thought we were twins, right? And when I read what you had to say, I have a slightly different. Right, exactly. A little bit different opinion on physician's role versus the institutional role, and the economics of that and the likelihood of being able to improve care with physicians. And AI that we refer to as the American Medical Association as augmented intelligence, help doctors to help patients as opposed to replacing. And as a surgeon, I can't imagine doing tonsillectomy and not having a surgeon involved. 1% of the time, the blank hits the wall, and all of a sudden, like, you better have a doctor around. And I know that, there's, anyway, lots to talk about there, but very much going to enjoy this conversation.
But where are you on colonoscopies? GI?
My husband's a gastroenterologist, so I can also comment on that.
Okay.
Well, so now I'm 54, and I had one done, and it was with a scope and not a device. And the economics, anyway, a lot to talk about.
Instead of I'm just saying.
I was a nurse anesthetist, doing the anesthesia with the gastroenterologist, doing the scope. And again, there's a whole lot to talk about. And I think that economically, that is down here as far as its impact on the cost of almost $5 trillion relative to all the other crap we can deal with before putting me at risk if the person around, when they take a biopsy and I start bleeding, isn't super comfortable doing that, right? There's just so much more that's low risk and enormous return on investment than that change.
So before I introduced myself, when I was standing back there, I was telling Megan, I said, oh, this is an interesting statement that's being made, because I agree 100%. When it comes to a procedure like a colonoscopy, I'm an oncologist. The chance of having, even that 1% chance of having somebody who is a technician but doesn't know what is abnormal, what isn't abnormal, missing a cancer diagnosis, then, oh, you don't have to come back for 10 years, and then 10 years later you have a metastatic colon cancer diagnosis. I've seen it. It's not good. And the 1 to 5% of the time that somebody's got a bleeding ulcer or has something that results in a complication, I definitely don't want a technician in there. I definitely want a doctor who has the intense and very... I did a little, but that's a conversation for another time, I think. So my name is Dr. Shika Jain. I'm a medical oncologist. I'm an associate professor of medicine at the University of Illinois Cancer Center. I'm also our associate director of digital innovation and communication strategies. I am also the founder of a nonprofit called Women in Medicine, a 501c3 focused on closing the gender gap in healthcare. And I also co-founded a nonprofit during the pandemic that was focused on fighting misinformation and getting people in Illinois COVID information and getting them vaccinated. And we got hundreds of thousands of people vaccinated, especially in underrepresented communities. We did a lot where it came to public health messaging and communication, partnered with physicians, nurse practitioners, social workers, community partners, grassroots organizations to really try to educate when our national systems were not really doing that great a job of providing accurate information. I'm also from Michigan. I'm from Kalamazoo, Michigan. Also the daughter of a physician immigrant. He moved to the United States and is a vascular surgeon. And I think this conversation right now is so important because of some of the things you all mentioned and some things I'm sure we're going to touch on today. AI and digital innovation is a huge part of what I do. I am a national media contributor as well, and I utilize AI in a variety of ways. I also think we're in a very scary time for our healthcare system, not only because our healthcare system was already breaking and we had I don't know how many people burning out and leaving, and we saw with the pandemic the cracks that were there really start to open up wide and turn into chasms. We now have a national health system that many people can't trust because information coming out is sometimes dangerous and inaccurate and not based in science. And so there's a huge opportunity here, I think, for AI to help, but there's also a lot of concerns to how AI can actually make things worse, and I think we're seeing both sides of that coin. So I think having physicians involved in these conversations is incredibly important, and having physicians lead in some of these spaces, because while technicians are great, we are the ones on the ground taking care of the patients. If you've ever seen the TV show The Pit, I think it's one of the most accurate representations of what many of us face in the healthcare space. So I think figuring out how can we be innovative, drive real change, and make sure that the people who you're sitting across from who are telling you a cancer diagnosis or telling you that you need coronary bypass also have that empathy that you'll never get from an AI bot, I'm guessing. But I do think that AI will be able to amplify and help us in how we deliver care. So really excited for this conversation with this incredible panel.
Good morning, everybody. It is a pleasure to be here. Thank you for convening. My name is Thomas Fisher, and as long as we start out talking about the role of physicians, my take is a little different. I think that the technical aspects of our job are probably the least important. Physicians are the ones that actually know the stakes of healthcare and are the ones that are able to communicate and demonstrate the sort of empathy that help people through their healthcare journey. The actual intervention of a colonoscopy or the surgery, that 7-hour period where they're in fact asleep and not aware, is important, but it is the surrounding component of that where you could never replace the human touch. The person who helps them understand what data means, what the information reveals about their lives, and help them to process these decisions through a moral, ethical, and value lens that AI can't do, shouldn't be expected to do. Neither should any other technologist. And to the extent that we see this more than anyone else and have the sort of human training and experience around what complications look like, what outcomes might be, that's the role of a physician. And it's a shame that that's not what we're actually paid to do. I am also the son of a physician. My father is a dermatologist and the first in our family to go to college. We are the descendants of American people who were held as property and experienced the worst parts of segregation. And after the Civil Rights Amendment, folks were able to go to school. And my father and all of his siblings got college degrees and masters, not because they all of a sudden became intelligent, but because all of a sudden they had opportunity. I grew up in Hyde Park. I practice at the University of Chicago, serving the community that raised me as an emergency medicine physician, and I'm currently on leave running for Congress in the 7th Congressional District, and we are in that district right now. I pursued that because in the process of my taking care of people on the front lines of healthcare, I've learned 3 things. One is that when you are caring for people in the days and moments that change their lives, these before and after moments, you quickly become a part of the community if you weren't beforehand. 2, you learn that we have this shared humanity, and while anybody can be in a car accident, slip and fall and break their arm, when they are facing a crossroads, it doesn't matter if you're rich or poor, black or white, man or woman, people have these intrinsic wants and needs that deserve to be honored in the clinical setting. And 3rd, I've learned that the game is rigged, that not everybody has similar opportunity to remain healthy, and certainly few people have the same opportunity to recover once they are ill or injured. And over the course of my career, I've been working upstream of these things, trying to resolve some of these problems, working in the first term of the Obama administration on health reform, working to implement through large insurers, building multiple companies, both in venture and in Medicaid managed care. And all of these systems are powerless to resolve much of what we face. And so, I was sort of radicalized on the front line of the pandemic where, I spent the pandemic wrapped in plastic and breathing through an N95 trying to save my neighbors. And watching these systems create vulnerability for some while others got to sit at home in front of screens made clear that until we solve societal issues, we'll never create health equity. And we'll certainly never create healthcare equity. And so here we are at a crossroads in American history where 17 million people are losing health insurance so that people like me and those of us in this room get a tax break. And I feel like it's time to stand up and time to do more. And I think that people who are in control of the systems that we are ought to also engage in constructive ways to create a society and healthcare system that reflects our values, reflects the fact that we are all one, reflects the fact that we don't all have similar opportunity to thrive, and reflects the fact that nothing is more important than the length and quality of our lives, literally nothing else. So I'm excited to have further conversation that's rooted in what healthcare really means.
By the way, I quote Tom. His book about his time in the ER during COVID on the South Side is incredible, and I actually reference it and quote it in The Coming Revolution. So, yeah.
So I'm going to go back to, we're just going to go right down the line to everyone, and now you get to speak when doctors are speaking, now that we've done all of the introductions. Where's the biggest breaking point for 2026 when it comes to healthcare? Because we're looking for, now not the most transformation in 10 years versus 105 years. Where do we think the next big break is going to happen, the big crack? What are you seeing that gives you a sense that we're going to see a disruption or a positive transformation in 2026 and the forces around that?
Yeah, I think that there's 2 aspects to this break. And I don't necessarily think the break in something that is going in the wrong direction is a bad thing. Right? I think this is a good thing. So one of them, I think, will be us, the people that suffer the consequences of something that needs to break, right? So this healthcare system. When I think about it in my community across the entire country, medical bills and debt being the #1 cause of bankruptcy, right? That's how huge this is. And I think that's something that will frustrate, hopefully, people enough to start asking for the change in the system, right? Because when the physicians are the main voice, perhaps the only voice speaking on behalf of patients, when we add patients to the yell, to the scream, I think that's going to help, right? And the other is the administration, the people that decide what we're going to spend in this country and on what. When they say, there's a right way to say it and a wrong way to say it. When they say 4 whatever trillion dollars, and it seems odd to say whatever because the point is a difference of $100 billion itself, right? So for them to say this is too much, we need to change this, is a totally reasonable thing. But what is the nature of that change? Is it to drop 10 to 15 million people from Medicaid to change that number? Or is it to keep us healthier and get rid of the waste that's going to change that number? And obviously, I favor the latter. And I think a lot of people, if not everybody in this room, favors the latter. Don't drop people from coverage, but deal with the consequences of something like the inefficiency of care, right? The fact like prior authorization, right? Having a patient that has stage 1 tonsil cancer that while waiting for a PET scan ends up with stage 2 tonsil cancer. Literally one of my patients. That's where the waste is. And so I think that those are the cracks that are going to help us sort of say, you know what, we got to break some of this, and then we have to rebuild it in a way that's better for our country and for the health of our country than taking us in the wrong direction.
So I'm going to start with the positive because I tried to start with the positive. So I'm going to say a positive break first. So as an oncologist, one of the things that we have seen really evolve and change the way we practice cancer care is precision oncology and precision medicine. It was a buzzword, now it's actually how we practice, where every patient who has a cancer can get testing for next generation sequencing, which basically tells us what the tumor is made up of, and that way we can personalize our cancer care to patients. And when we talk about equity, I work at a public hospital, I work at the University of Illinois, I'm able to provide that level of care to patients who, 10, 20, 30 years ago may not have had access because it was the haves and the have-nots, and the have-nots didn't have access to it. But now I'm able to provide access to that. So from a cancer standpoint, we're able to provide more and more personalized care. We're able to provide more and more precision care, and we see it not just in oncology. We see it in allergy immunology and rheumatology. There's a lot of fields where we're seeing personalized care based on the person's makeup, their genetic makeup, their background, and we're seeing a real push to get more and more people who have not been in clinical trials into clinical trials. Drug companies want more diversity in their clinical trials. We are seeing hopefully more data coming out that's representative of our population as opposed to just a select portion of our population. Up until recently, I think it was like 90% of people enrolling in clinical trials were white, and it wasn't until the 1990s that women who were able to get pregnant were required to be included in NIH studies. So we're starting to see a transition and a transformation where we're seeing more and more people being hopefully represented in the way we're doing scientific research as well. Now let's talk about the negative, what's happening right now. And when I talk about these things, I'm very clear. I'm not running for any political office, and I don't talk about my political leanings one way or another. I talk based in science and evidence. Misinformation coming from the highest offices in the land that are now resulting in decisions being made on opinion, based on opinion, not based on facts, is going to be one of the biggest public health crises that we are going to see. We are going to see an increase in liver cancer because patients, especially in those communities who don't have great access to care, are not going to get their babies hepatitis B vaccinated. We're going to see an increase in hemorrhages from babies who aren't getting vitamin K shots. I've had adult patients come to me with low health literacy saying, Dr. Jane, I can't take Tylenol anymore because it's going to cause autism. This is a 65-year-old black man who has a diagnosis of colon cancer, who can't take other pain medications and can only take Tylenol and is now in pain because he thinks it's going to cause autism. This fact of horrifically inaccurate information coming from the highest offices in the land being masqueraded as fact, and then doctors and nurses and healthcare workers being basically attacked, criminalized, being told that they are trying to make more money. I had a patient yesterday in clinic tell me, Dr. Jane, I don't trust you anymore because the government tells me you're just in this for the money. And I turned to her, I said, ma'am, there are a lot of ways I could be making a lot more money than sitting here talking to you about why you should get your flu shot. Honest to God, I've had people tell me you're getting a kickback from flu vaccines and what money are you putting in your pocket? So this misinformation, it's killing patients. It's killing people. We're seeing it in real time. I've had patients who believe the things that are coming out of the national government, which we should, right? We should believe our national agencies. But I think that misinformation is going to widen these really bad disparities that we already have, that we've been working so hard to work towards driving change. I think it's going to make things worse. We're already seeing it make things worse. And then one comment on health insurance and prior authorization. So I've written a lot of pieces, done a lot of work in the prior authorization space. I've had cancer patients who have died waiting for things to get approved. I've had patients who've gone from stage 3 to 4 waiting for imaging to get approved, despite me calling the insurance company and saying, my next call is to CNN to tell them how you're killing my patient. So these are the types of things that I think we really can focus on. And I think the fact that health insurance premiums are about to go way, way up is going to be a breaking point. I think a lot of people are going to realize that they can't afford healthcare, and we're going to see our emergency rooms overrun. We're going to see preventative health overlooked even more than it is now, and we're going to see a real problem not only for our patients but also for our healthcare workers. Part of the reason we were seeing burnout before healthcare is still there, before COVID is still there. Since COVID and since this rise of misinformation, I'm seeing more and more doctors just say, forget it. I can make more money as a consultant and I won't get attacked in the hospital. So why am I doing this? And a lot of people went into medicine to help people, and because we're altruistic, we care about people. I'm seeing less and less of that because those people are burning out and saying, this isn't worth my time. I need to protect my mental health, protect my family, and get out of this career. So I think that's going to be a huge breaking point, and we need to focus on our healthcare workers and our staff and our support staff, because the way we're going is not going to be good for our system or our patients.
Yeah, I agree. The system is breaking in fundamental ways. I wish I believed the country really cared about that, because if we really cared about it, we'd have done something about it a long time ago. So for me, where I see a fault line coming, I mean a real break, is going to be with institutional failure. A short story, I got into a war not of my own making with the number 2 person at the University of Minnesota a couple of years ago, because I wrote something called Minnesota Madness in a piece about academic medicine, where I said the title was Academic Medicine, Where Privilege Compounds Dysfunction. You probably guess where I'm coming from on that. But anyway, so I had as an example what the University of Minnesota was doing. They had a very public breakup with their clinical care partner, which is called Fairview, and who started the process of terminating the relationship. And the used solution was to get $3 billion from the state government of Minnesota to buy the Fairview hospitals, to build a $1 billion plus new patient center in Minneapolis, and, oh, by the way, $75 million a year in working capital just to make it all work. And so I talked about how dumb that was, and they actually had a website called Impact Minnesota with the block M for you. And I'm from Minnesota originally, so this kind of hits home for me. And it said, the bridge to a healthier Minnesota, like somehow spending billions of dollars more money on inpatient facilities in Minneapolis was going to cure chronic disease and improve life expectancy in Minnesota. So anyway, I wrote this, and Governor Walz, who nobody knew at the time, convened a blue ribbon task force to figure out what to do with health education in Minnesota. And my article ended up being part of the reading list for the task force. And so he wrote a equivalent of a 3-page letter to the chair of the task force, basically saying, one, I didn't know what I was talking about. And then the second thing was talking about all the great things the U was doing for public health, and not one mention of any of the money they wanted for capital investment and so on. Anyway, the U ended up having a pretty bad day, even though it looked like the task force was set up to see. So they got no money for the new facility, they got no additional working capital, and they wanted mandated arbitration with Fairview, and they didn't get that. All they got was a study. But the issue is the institutional failure issue. And arguments like this are going on, David Bierik's here, are going on in Oklahoma and Tennessee, with the University of Tennessee and University of Oklahoma. I think we will see some major institutional failures. I can't tell you who exactly or when, but the economics aren't squaring. And I used to do tax-exempt bond issues for a living, and we will see some major health systems default on their bonds. You just can't continue to lose $100 million a year from operations. So I don't think until we get major institutional failure that the sort of country overall will wake up. I mean, we just shut down the government over the supplemental Obamacare subsidies, which actually does nothing to address any of the problems we're talking about. Some people are going to lose insurance, and I am in favor of extending them. But all it is really doing is just pushing more money into an already, inefficient system. So.
I think the breaking point is I categorize it as people versus profit. And I don't think we've wrestled with this sufficiently in a head-on way that allow for us to find our path yet. I see it in the emergency department regularly, where I will diagnose somebody with a new cancer and have no place to send them because they're uninsured, and we already have an overextended system with folks who are in care. So we have to send them somewhere many miles away from home for their further diagnosis, biopsy, and care. But I see it on the other side, where the worried well and wealthy are exploited for things like full-body MRIs that are not demonstrating any value whatsoever, but are simply profit-motivated systems trying to take money out of your pocket. Our healthcare should be something bigger than that. And because we don't have any value basis to our healthcare system, our leadership is rudderless when it comes time to reconcile these challenges. I had a patient in the emergency department about a year ago who had an accident. I mean, it doesn't really matter what happened to him, but he had a fractured face. He had an orbital fracture that required a plate in order to ensure that his vision wasn't compromised. He was insured. We have eye surgeons. I connected all of the dots. They were prepared to repair his face, but he wasn't in network. So, does he get the surgery anyway and face a massive bill? Does he go home and try to navigate a system to figure out where he can get that operation in a timely fashion? And whose fault is that? Is it the insurance company who we're not in network with? Is it the hospital for not having them in network? Is it the individual for not knowing where to go? I mean, this is one of the many ways in which we hold individuals at peril in order to make systems efficient for profit making in a rudderless, valueless healthcare system. That individual, when his vision is at stake, should be cared for. Full stop. But that isn't what we've constructed, and this tension between people and profit will not get reconciled until we have the sort of leadership that recognizes why do we do this at all, right? It isn't for margin, which is what nonprofit places will call it, or profit, which is what profit places will call it. It's to help people when they are most vulnerable. And I think we're facing this turning point for reasons that I've heard others say, which, like, misinformation is a scourge and it is going to be catastrophic. We are going to see system failures. And when that happens, there's an opportunity. It is not when things are going well that you actually create change. It's when things break. We are on that precipice, and if we have the sort of leadership in place that recognizes the point, we can actually build something better than what we've had. I'm not interested in going back to what we had before Trump, right? I think that there's a lot of impetus that says, like, this beautiful bill was bad, or the science war is not so good. But look, I was practicing 15 years ago, post-Obamacare and pre-now, and it still sucked. Like, we actually need to build something better in the future and create something that we have yet to see. There's a creative process ahead of us that we have to embark upon that is not simply going back to the old saws that have failed us to this point. We should not be confused about that.
And I just want to add one thing, this comment of people over profit. So I think one of the reasons we are where we are today is because healthcare from the 30s, 40s, 1930s, 40s, and 50s to where it is now in 2025, it became a for-profit business. Even if you are a nonprofit hospital, it is a for-profit business. And the problem is the people working in the healthcare system, the doctors and nurses, we are there to take care of the patients. The people making the decisions about what's happening are the people who are looking at the bottom line. And we cannot function like a corporation. We cannot function like a business because people's lives are literally at risk. When I was admitted to deliver my children, I got a bill where my OB was in network and my anesthesiologist was not. I did not pick the anesthesiologist for my emergency C-section. I was at Northwestern. That's where I was delivering my children. But all of a sudden, I'm fighting with the hospital because the anesthesiologist that was on call was not in network. So all of a sudden, my bill tripled. I mean, this is not how healthcare is supposed to work. We are not supposed to be functioning as a business. At the end of the day, it's exactly like Dr. Fisher said. If you need care, you need care. And we should be caring about the people, not about the bottom line. Now, obviously, the hospitals can't go into debt. They can't be bankrupt. They can't go in the red. I get that. I'm not stupid. But the way that things are set up right now, these hospitals, these systems, the entire system is set up like a business. And you can't create a business out of people's lives, out of people's health care. And that is where we are. So I totally agree. We are at a breaking point. And I mean, we always, what do they say? You have to hit your rock bottom to start rebuilding. And I think the question is, we thought we were at rock bottom 3 years ago. And I think the bottom just keeps getting lower and lower and lower. So at what point are we actually going to say we're at rock bottom? And I think we're right about there. And we need to start rebuilding in a way where hospitals are not for profit. Hospitals are for people.
Can I just amplify your words for a second, Dr. Jane? Because I agree with everything you say. And I want to be a little bit charitable about the administrators of our institutions in that certainly physicians and patients are clearly trapped in a system that we are powerless to improve and have middle people in between that relationship that influence our care. But I think that administrators are trapped too. By groupthink, by quarterly reports, by boards that say they must deliver certain results. And until we have system change, it's not enough for an individual to say, look, I think we ought to change. Everybody in the room must have a similar playbook, and they do not. It's the business schools that they went to 25 years ago that helped them think through how to solve problems that prioritize a number on a spreadsheet as opposed to a patient in a bed. These are the reasons why I'm running, because this won't happen piecemeal. This will happen when we come together and recognize that we need something different.
And that's why we need more physicians in office, and we also need more physicians in the administrative space, and we need more physicians who've actually seen the patients, who've actually gone through, who can tell the stories, right? When I was telling an administrator about some of the stuff that happens to me, and they care, they do, but they are stuck in a system. So that's why I personally think we need more physicians, more nurses, more people who've actually done this work, who've been on the ground, who understand the nuance, who understand, my patient can't get chemo because of this issue, or the hospital is causing these challenges. And again, it's not not all the people in administration, some of them. Some of them might not be that altruistic, but I think we need to have more physicians and healthcare workers in those leadership spaces to be fighting and advocating for our patients.
There was a rapper in the 90s named, I think you can correct me on this time, 50 Cent. It's not
50 Cent.
50 Cent.
50, yeah, there you go. I always get it wrong. And he said, don't hate the play, I hate the game. It's a shitty game, honestly, people. It's bad, as Tom was saying, Dr. Jane, Bobby. So the real question, I think, is, I'll tell you, because hearing from a lot of doctors here, I would argue we don't have enough business people in some ways running this. So Terry Shaw, who's just retired from Advent Health in Florida, former CFO to CEO, really one of the best in the country, in my opinion. I was talking to him not too long ago, and he said two things that were really pretty interesting. He said, healthcare's always been a cottage industry. It's now the cottages have turned into hotels. These are gleaming palatial structures. Is that really what we need to provide the care we have to provide? And then the second thing he said, and he didn't let me quote him. He let me quote him on the first one, but not on the second one.
This is being recorded, Dave.
He's retired now. He can live with it. And he's from, but he basically said they'd had to, because they've on 5th generation of their app, and he's really focused on how do we improve end user experience. And he ripped out the phone system, computers in every institution across 7 states, enormously expensive. And he said, because we're not going to have any more phantom appointments, right? So when you go on the app to schedule you're going to get a seat. And his way of describing that was the doctors in our system don't get to decide how busy they're going to be going forward. So all due respect to everybody on the panel, we've got issues with sort of the training and the institutional behaviors inside of these systems. So I think Tom's right. We need to create something entirely new.
Thank you. This one might be dead. Oh, there we go. So, yeah, now I got it. So much to say. Let me start with the first comment after I spoke originally about precision medicine. I think it's amazing. Just a quick story. 48 hours from now will be the 1-year anniversary of my diagnosis with brain cancer. I had surgery 363 days ago, and I'm alive, and there's 10% of this cancer left. It's amazing, the research that basically, it took about 3 weeks for me to get my pathology, and it was this sort of precision medicine, and it turns out that I have a cancer that's responsive to a medicine that got approved like 90 days before diagnosis after more than a decade of research because of NIH funding, right? Which peripherally is obviously under major threat right now. And so this, in fact, I went to grab it to show you. So these medicines right here, this is 7 days worth, $6,300 in my pocket, right? So again, another example of where we can affect how much we spend on healthcare in this country. And then the other things that came up, the institution-based care, right? It used to be a hospital, it was where you went when you got sick. Now, if you want a colonoscopy, you go to the hospital, and it costs 3 times more than if you just did it in the community practices where our parents' generation, those of us who all had physicians as parents, they would just do this in the community at a fraction of the cost with an amazing relationship with their patients that never led to this burnout. Like my mom, as a retired pediatrician, would come home with a stack of charts before electronic health records. She would feed us, and she would sit down, and she would finish all her charts right about the time where it came for bedtime. She'd put us to sleep, finish her charts, go back in the morning, and do it all again for decades, and loved every day, right, with no burnout. And now, good luck hitting age 60 in this environment, right? And I think that's because of the institutional influence on the nature of care, right? When it becomes more expensive, when it becomes a source of frustration for those of us that are closest to who we're trying to help, the patients, I think is all stuff that should crack to improve it.
And I want to add something about the comment made about we need more business people in taking care of the systems. So I'm going to push back on that, and I'll tell you why. Because when business people got involved, this is what happened. My husband's a gastroenterologist. He has a patient who wants to do an upper and lower endoscopy, okay? They need an upper and lower endoscopy, and he's like, I can do that. Great. We'll schedule you on Tuesday. The administration says, nope, we can get reimbursed more if you do the upper on Tuesday and the lower on Thursday. So have the patient come back twice. And my husband said, that's stupid. Why would I make this poor patient take 2 days off of work, come in twice? And that's because an administrator made that decision. A cancer patient comes in. Patient says, Doc, I want to see you, but I drive 5 hours to get here. I'm going to drive 5 hours each way because I love you. You're a great doctor. And the administration says, nope, sorry, we can't see this. You can't see this patient. So I would challenge, if business people want to be making these decisions, they need to sit in these rooms with us and tell the patients themselves why they can't get the care that they need, why these patients can't get the care that they want, why they can't get the care they deserve. Because when I'm sitting there and saying, sorry, the hospital's telling me I can't do this for you because of this reason, then I'm the enemy. And it's not because I don't want to do it. It's because I've been told by administration I can't. When my husband has to tell somebody, sorry, you have to come in twice to get, I could do the procedure all in one day, but we can bill more if we do it twice. And those are decisions that are being made with the bottom line. Now, don't get me wrong. A lot of doctors suck at business. They just do. They don't care, and they don't want to care. They just want to go in, they want to see patients, they want to go home. That's great. But when it comes to actual decisions being made, we can't think of it as cookie cutter medicine. Everybody has to be treated differently. Different patients have different requirements. Like I've got patients who are long haul truck drivers. So I personalize their care based on, okay, well, I know you'll be gone for these days, so I'll schedule you on these days. there's things and decisions that we make that can't be systemized. They need to be personalized. And I'll tell you, people who have money, they go in and they expect the care that they want, and they will pay for it. There's concierge practices popping up all over the place. Most patients can't afford that kind of care. And so we really have to think critically. Yes, 100%. We need business people helping make decisions, keeping the lights on, making sure the hospitals are running. But medicine is not a business like, we're not building widgets, right? We're making decisions that are literally, truly life and death. And if an administrator is going to tell me I can't do something to save a patient's life, then they need to be sitting in the room telling the patient themselves that, I'm sorry, we can't save your life because of this reason. I tell my peer-to-peers when I do these prior authorizations, I actually told one of the people, I was like, my patient's in the room with me now, I'm gonna put you on speaker. You tell the patient why they can't get this treatment because you are going to literally sign their death certificate. And the first time I did it, I got an approval right away. So I think that there's a big difference because what's happening is the onus is falling on us. I'm sitting in the room, I'm telling the patient, I can't do this for you. Things get delayed, I get angry patients calling saying, why is my CT scan not scheduled yet? We are the ones who are the face of these decisions, and these decisions have been taken out of our hands in many cases.
Okay, I'm watching the, no, I do not. I do not. Okay, but you'll have the opportunity, of course. So what I'm going to say now is I'm going to throw one more complexity down, and then I'd like it, if possible, we can then spend more of the time sort of identifying solutions, but also problems to solve, as, of course, my colonoscopy is just sort of a red herring designed to antagonize gastroenterologists, who I love deeply. So I noticed the headline in the New York Times this week about how Illinois is a leader, and I'm so excited about this. Carbondale, Illinois is a leader in providing abortion care. It is not just that we have changes in federal law, but we, of course, have state-by-state differences and variations. And a decade or two ago, I would have said, well, maybe if you've got money, you can go to perhaps India to have your knee replacement and recover on a beach. It'll be beautiful. But now we have people in the United States needing to do a little bit of medical tourism themselves to get life-saving and life-protective care. So I want to just sort of throw in, how do we think about not only facilitating federal change, but are there any things we also need to be thinking about how our neighboring states are now creating a really distinct patchwork in the types of care their citizenry should get? And Dr. Bobby, I'm going to start with you. But then after that, we're going to put our happy bring the holidays home hat on to identify problems we can solve, but also reasons to be optimistic if that's possible.
Yeah, I mean, it's unfortunate. The American Medical Association was very disappointed when something about reproductive health care in our country went from a national decision that the Supreme Court said this is what we need to have access to now 50 individual decisions at the state level that sometimes fight like heck to protect the physician-patient relationship and having those conversations, to working hard to make sure that the patient-physician relationship was irrelevant to this. So how do we deal with that? I think that what I noticed is that when our patients, when our voters get involved in stating their opinion, it's pretty clear what that opinion is going to be, right? And so it changes the nature of the conversation, where it's no longer sending somebody to Supreme Court to give testimony, but instead, it's the patient-physician relationship that basically says, look, this is coming up, and this is an opportunity to share what you're sharing with me in the exam room with our lawmakers. Right? And so that's something that I see as a necessary, unfortunate development that will help patients get the care that they need. But in addition to that, I just wanted to also touch on something that came up, and you mentioned it, I think, in a way that isn't coincidence. And so rewind this tape to a year ago, again, when I got diagnosed with this brain cancer. About 5 days after that diagnosis, I had signed up to take my board exam in lifestyle medicine because I thought this was an amazing opportunity as president-elect of the American Medical Association at the time to talk about how we can improve the cost of care, but do it in a way that improves our life expectancy, improves our health. And so I told my wife, I'm like, I'm going to still take that board exam. And she was like, why would you do that? You just got diagnosed with brain cancer. And I'm like, look, this is a win-win situation. If I fail, I've got the best excuse on the planet for having failed this board exam. And if I pass, it'll be miraculous. And so I went to take my first sort of computer-based exam where it's like going through TSA to take this exam, and I sat down and I passed. So now I'm lifestyle medicine board certified. But those principles came up, which is 7 hours of sleep per day, right? A plant-based diet, exercise, minimizing alcohol, not smoking, social interaction, stress reduction, right? These are the principles that will save an enormous amount of money if your primary motivation, which is kind of what our lawmakers have as their main motivation, is this going to help us or hurt us dollar sign wise? That'll help. But if you're looking at it from a social perspective, like how long are we going to live if we do this? That's a no-brainer, right? The life expectancy, I live in the city of Flint. Life expectancy there, 68 years. Where I grew up, where my parents live in the suburbs, 10 miles away on I-75, 81 years, right? And the reason, part of the reason, again, there's multiple reasons, from violence to groceries. The grocery store, we don't have a, what's that really fancy place called? Whole Foods, right? I'd say 90% of the people in this room know exactly where the closest Whole Foods is, and it's probably not that far. For us, it's like an hour away. Instead, what's 5 minutes away is a grocery store that has a bunch of food preserved with salt, so the shelf life is good, stuff that's a little bit rotten that nobody else wanted to buy, that Whole Foods said no to, but Flint Grocery Store said yes to, right? And so these are amazing opportunities to improve healthcare, not with the, unfortunately, 15 minutes that I may spend with a patient, but the entire spectrum that affects the health of that patient, from where they get their groceries, right? The AMA has made a big investment with Rush on the west side of Chicago, West Side United, to basically say, look, our traditional interaction with the patient is right here when they come in for 15 minutes in the office. But the stuff that affects their health is from here to here. And let's invest in improving that so that we can change the metrics and take a 68-year life expectancy. And heck, if in my lifetime we got it into the 70s, not quite to 80, which is what I'd love it to be, that's a huge improvement and totally worth the investment instead of doing things like hospitals do. And one more demonstration of profit or nonprofit, it doesn't even matter. That's just a label. So we have a hospital, that one of the three where I operate, that decided to be the first hospital in the state with a proton machine to treat cancer, right, instead of the traditional sort of radiation therapy. This hospital decided, you know what, we just don't want to buy a product. We want to own the company that makes this product, because once it catches on, we want to sell a lot of it. So they invested in this company, bought this machine for tens of millions of dollars, and the thing worked like crap. For 3 years, it didn't work because the beam that was coming out was too big to focus on one thing. 3 years later, they finally tweaked it enough that it worked, and then all the advertisements broke out, billboards about, hey, you got prostate cancer? Come see us. We got a proton beam, machine. What I would love to see on I-75, where I live, where the life expectancy is 68 years, life expectancy, is, hey, do you have stage 1 hypertension, which half of us don't even know that we have? That's in your book too, David. Come in to see us, and we'll help you from developing stage 2 hypertension. Right? Do you have pre-diabetes? Come in to see us, and we'll prevent you from, having type 2 diabetes or type 1 diabetes, even needing an amputation. Right? I'll never see those billboards in my hometown unless what we're talking about here resonates. We'll live longer. We'll live healthier. Hospitals will again become the place where you go for acute flare-up, right? Like if I got a brain tumor, I'm going to need an operation. I'm going to go to a hospital to get that done, and I did. But how about all this other stuff that will affect my health, that will affect the health of the community? That shouldn't be centered at an institution, right? Because those institutions, when you go in and you've got a healthcare issue that's, something early on before it becomes acute, the reason that hospitals want to do it is not because they're the experts in that or it's cheaper to do it there, but every test you get, you go to a lab to get your white blood cell count and your hemoglobin, and that lab is in the hospital versus in the community, it costs more. There's profit to be made, even if it's a nonprofit institution. And that's absolutely what we need to change. And I don't even think even if we don't decrease it a dime, if it stays at 4 trillion dollars, if we're a healthier country and don't spend a dime more to do it, but instead change these things that we've been talking about, that would be awesome.
So first, I want to say I love living in Illinois, and I loved seeing that article because I love Illinois. I grew up in Michigan. I love Michigan too, but I love Illinois. I want to echo something that Dr. Bobby just said, which is even in Illinois, there's actually something called the blue line effect, where depending on where you live on the blue line, that directly impacts your life expectancy. There's actually data that shows different areas on the blue line show different life expectancy. And that is it the green line? I thought it was the blue line. Oh, it's a green line. Sorry. See, quoted wrong. Green line. Thank you for correcting. Misinformation. Sorry. So the green line effect. And the interesting thing about that is, again, it's access. There's food deserts. There's hospital deserts. So there are a lot of things that I think we really should be doing and can be doing to mitigate that. Going back to what you asked about, though, you mentioned about, reproductive health and the Dobbs decision being overturned. So obviously, I started this nonprofit, Women in Medicine, 9 years ago, not knowing we'd be where we are today. And it's a scary time in the world to be a woman, in the United States to be a woman. It just is. I know people who are no longer traveling to certain states because they're pregnant, and if they end up having some sort of complication, they're worried they're going to die because they'll go to the hospital and the doctor won't treat them because the doctor is worried they're going to be sent to jail. I think that a lot of the decisions that have come down the pipeline recently, actually, let me step back for a second. I think lifestyle medicine is fantastic. I think healthy eating, cutting down alcohol, no smoking, all those things are super important, and they can absolutely prolong life. And I think about 5-10 years ago, we were heading in a direction where we had a lot of great things happening in our healthcare. We had, not everything wasn't great, but in integrating things like lifestyle medicine, we were really heading towards we can increase our lifespans, we can live longer, we can do all of these things. We'll start seeing the lifespan of Americans increase. Unfortunately, I think some of the benefits of that for many populations are going to be canceled out by the negative things that have happened in our healthcare system. For example, overturning Roe v. Wade, which we know is going to decrease life expectancy. We know that Black women are more likely to die if they are pregnant. And the types of protections that were in place, the types of innovations and interventions that were in place to address that are being rolled back. The whole Hep B vaccine issue right now, that is going to result, as I said earlier, in more long-term liver cancer, or long-term liver disease, liver cancer. People being anti-vaccine. We know the flu can kill you. We know COVID can kill you. We know that getting vaccinated against pneumonia can be protective. So my big concern right now is the health decisions that have been made that we're now leaving to the states in some situations are actually going to result in the lifespan of this country dropping, because while we started to implement these great lifestyle interventions and we focus more and more on holistic care, if the basic medical innovation that we have seen that prolongs life in the last century. I mean, vaccines were not around 100 years ago. That's why we're living longer. Preventative colonoscopies, screening mammograms, these types of things were not around. We are seeing today why we are living so much longer. It's because of this medical innovation. And what's happening right now is terrifying for those of us in the healthcare field, because what we're watching is scientific-based, evidence-based things that we know have extended people's lives getting rolled back or having misinformation around them is resulting in, especially those who have the lowest health literacy, those who are the most impacted by this, we're going to see life expectancy drop because they are hearing things and regulations that were in place and mandates that were in place that were really put in place to help people are being rolled back. I think Florida just came out saying that they're no longer going to require vaccines for kids in school. I mean, these types of things we have seen have saved lives. We have seen them extend our lifetime. So I agree that lifestyle medicine and getting those grocery stores, getting those healthy options, cutting down alcohol, all of those things are incredibly important, and they need to be integrated into how we're delivering care, and the hospital needs to be a place for acute care. However, and really, I would love to see more and more of the primary care type interactions that we saw in the 50s and 60s, where you've got a good relationship with your doctor, you're going to the clinic for these types of things. My fear is where we are right now, and where it seems we are heading is we are completely discounting the science and the evidence that's gotten us to the point where we are today. We're rolling back protections, and those protections are going to have a negative impact on the healthcare of everyone. And the fact that we're seeing in Illinois, women come here for abortions, women coming here for prenatal care, but these are women, again, who can afford to be medical tourists and drive across state lines. There's been questions in some states of women being targeted and criminalized for crossing state lines to get an abortion. I mean, this is not the country in which we live. This is a country of freedom and democracy and being able to take care of yourself and your own health. The fact that we're getting to a point where our health is going to be determined by the state you live in, by the zip code you live in, we've already seen it, but it's getting worse. And I'm very concerned as to where we are going to go as a society when science is not our guiding light, when opinion and political grandstanding is where we end up. And again, I'm not saying this from either side of the aisle. I'm not a politician. I'm saying this as a physician who sees in my clinic and talking to physicians across the country with all of the work I do. What we are seeing is dangerous, it's scary, and it's going to negatively impact the lifespan of this country. And I think that there's a lot to be said for what we can do as a society.
Less than 30 seconds, I promise. So where science, exactly what you just said, where science takes us is to the point where my life expectancy without these is 10 years, right? If you Google, glioma of the brain, 10-year life expectancy. Because of this, who knows, right? I might live till I'm 80 like I'm supposed to. But right after I started taking this, literally within a month, because my surgery was in December, January, new administration, NIH funding gets dramatically cut as far as the government ability to contribute to NIH funding. So again, where science takes us, policy goes in the opposite direction many times. I'm supposed to live longer. If I wasn't lucky enough to have this approved, I'd be living 10 years instead of 20. Science takes me this way. Bad policy takes me this way.
Okay. Lynn, you were trying to end on a higher note here.
Sorry.
No, that's okay. Oh, can you hear me now? Yeah. He doesn't have to call me Johnson. That's for Dave Burden in the corner. We actually know what to do. I mean, other advanced countries are much better at getting the balance right between health investment and healthcare investment. Bobby, I'm glad you mentioned West Side United. Dr. Jane, I'm glad you mentioned the Green Line and Death Gap. That's David Ansel, physician at Rush, who wrote the book Death Gap and put that language into the lexicon. He basically said, you start in a loop and you go to Garfield where he practiced, West Garfield, and the life expectancy difference was 16 years. When he wrote the book, it's now over 20. Now, I happen to be on the board of the largest nonprofit developer of affordable housing in the country, and we're going to open in the next month or two something called Sankofa Village in Garfield Park. It's called Sankofa Health Village. It's going to have the first brand new YMCA in Chicago in, I think, almost 15 or 20 years. There'll be clinics. There'll be a federally qualified health clinic. It's basically going to be a wellness center. And the CEO of Rush, Omar Latif, who's a great guy, says the basketball court at Sankofa will save more lives than the ECMO machine at Rush. And I think he's right. By the way, talk about lifestyle medicine. The secret to living a long life is just not to get sick. And there are ways to not get sick, as Lynn was talking about. But here's where I want to go. We know what to do. It's just getting it done that's hard. And you asked specifically about state-based care. And I think somebody can get elected president of the United States, a governor, by making the statement, we want Illinois, Colorado, Utah, Montana, pick your state. We want our state to be the healthiest state in the country. And what do I do day one? Day one is I make that statement. I hire the Gates Foundation, Commonwealth, whoever, and come in and say, tell me how we measure this, and I challenge every other governor in the same state. The other thing I do simultaneously is I create blue ribbon panels to look at health education and look at medical regulation in the state, most of which actually protects the industrial complex that we have today. So soup to nuts, how do we become the state that trains the best health professionals broadly, interprofessional, interdisciplinary, empathetic, science-based, all of those things? How do we become the state that's easiest to cross state lines, practice at top of license? How do we do all of those things? And instead of knuckling under to the political pressure to keep things the way that we are, so you can't read an X-ray in Australia off hours without getting it signed off by, I mean, you get rid of all of that, and then that's near term. That's what I do now. Medium term, I get the mother of all waivers from Congress, where I start to pay for health outcomes, not for process. You know, we've had a lot of talk about business of healthcare and so on. Charlie Munger, who was Warren Buffett's partner forever, used to say, show me an incentive, I'll show you an outcome. He also used to say, show me a stupid incentive, I'll show you a stupid outcome. We have so many stupid incentives, and that's what leads to your situation where somebody who needs care and the administrator saying, no, it's back to 50 cents. Don't hate the play, I hate the game. Game's bad. And then long-term, what am I doing? I'm every community group I go to, every business, every school, every religious institution. What are you doing to make us the healthiest state in the country? And then, you know, create a movement. But we aren't going to get to where we need to go unless we stop doing it the way we're currently doing it. Deming, the big management consultant, said, you can't do something new until you stop doing something old. Well, there are a lot of things we need to stop doing. We know what the right thing to do is. We need to shift investment into all these different areas we've talked about out here. So how's it going to get done? And I think it will start at the state level. And guess what? If Colorado suddenly does this and their people are living 5, 7, 8 years longer than everybody, other states will copy it. Trying to get that done at the federal level right now, I think it's too captured.
The idea that people in New Orleans who need reproductive care have to travel to Illinois is a reflection of a broken democracy. When it comes right down to it, abortion care is popular. The majority of Americans are in favor of having it safe and legal. Same with gun control. The majority of Americans are very clear that they want fewer school shootings, they want fewer weapons in the hands of criminals, they want fewer high-capacity magazines, they want these things. The fact that none of these things are occurring is part of this larger trend of what was versus what needs to be, this, you know, the old versus the new. It's also reflected in the fact that people under 35 don't think they can ever own a house, and they might be right, unless things change. And so this rolls up to the fact that we are on one of these two sides, and I think each of us individually has to choose, are we part of what was or what will be? Because we can't straddle that any longer. And I think that there are systems that are struggling to hold that tension that will make a choice, and history will reveal itself. I think there are a few things we can do differently. I'm really going to only name 3, and I'll try to be concise. The first is we need moral leadership, period, full stop. Our budgets are moral documents. Our policies are moral. And I think that that trickles into a generation of leadership that may not have shown us what that looks like. I think academia needs to know that its point is freedom. And if there isn't academic freedom, it's not clear what the institution is for. It's not clear what law firms do if there isn't the rule of law. What is healthcare if it isn't serving people? That kind of moral clarity needs to come from the board and the C-suite, and if it's ambiguous, these institutions, what's the point? Our government ought to be providing food to the hungry and healthcare to the poor. But we're having SNAP benefits cut and Medicaid cut. What is the point of these institutions without moral leadership and clarity? That is people, their incentives, and choices that we need to make moving forward. So that's one. Two is we need to just stop the bleeding, right? I'm an ER doc. There are certain things that we need to do today to just stop the bleeding, right? In all of these healthcare institutions, they have quality metrics that guide their services. They need to be applied to people consistently. In the emergency department, we know how many people get restrained in the setting of mental illness. We know what our door-to-needle time is for acute coronary syndromes. We know how many people get thrombolytics for stroke. But do we know how often that happens in off hours, or for people who are uninsured, or for women versus men, or black versus white? And if we're not looking at those outlier events, are we serious about equity and quality? We might be serious about equity, but we're certainly not serious about quality if we're not looking at those outliers. And then I think the third thing is we need to build new things. We can't simply be looking to refine old things. Let's say I waved my magic wand and I had Medicare for all, or some other universal care system that ensured everybody had the resources to get care. We'd still need to knit together a fragmented system. We'd need to provide services for people who have not traditionally gotten what they needed, like for substance abuse disorder, or substance use disorder, or mental illness, or some of the chronic diseases. We'd still need to deploy technology to ensure that the limited number of providers we have could work at the top of their licenses and serve for all of these people who are suddenly able to get care within our systems. We don't need to wait to build those things. We should build them now. Let's just start constructing the future of healthcare and start to abandon some of the things that are not serving us well any longer. The creative notion that we have to see a future and create it should be the core guiding principle. And then with the recognition that we cannot then charge $3 million for a cure for cancer, because our 18% GDP healthcare system will quickly become 35%. And we'll be making choices between roads and medication. Or we'll be limiting these resources to only the small handful of people that can afford them, which means the life expectancy for people in this room goes to 120, and the life expectancy for people on the west and south side goes down to 50 years. Either we're all in this or we're not. And I think that if you believe, like I do, that we have a shared humanity, then it's clear we are all in this. That's moral leadership.
Dr. Fisher mentioned just one thing I just want to give my thoughts on. So there are some things to deal with the fragmented aspect of what we're dealing with now in healthcare that will take a decade or more to fix. There are some that we could fix in 1 year. And the one that just burns me up is if you see a patient here in Chicago, and then that patient comes up to Michigan to spend their summer in Traverse City, and they've got a condition that got diagnosed here, and you got to share it with the emergency department in Traverse City, you're using a fax machine, right? In 2025. I said that at the Consumer Electronics Show. The entire audience of non-physicians that were in electronics they just laughed. They're like, "You're still using a fax machine, dude?" I'm like, "Yeah, every week or every month sometimes we go to Sam's Club."
Right?
Yeah, exactly. I go to Sam's Club to get fax toner. And they couldn't believe me. But that's something that can deal with the fragmented nature of healthcare. Technology. That you deal with the fragmented nature of healthcare in less than a year, right? If all we just pass a rule that says, "Hey, look, if you got an EHR, it better talk to my EHR." And have it, I mean, my Verizon phone talks to your Sprint phone, right? That's a no-brainer. The fact that my healthcare system, my EHR, doesn't talk to yours, that is so simple to fix, to decrease the fragmentation, the first step.
And I'll add something that Dr. Fisher said as well. So one of my good friends, Dr. Megan Ranney, is an ER physician who speaks about this, and she spoke at our Women in Medicine Summit about this a few years ago. It's this concept of old power and new power, and Dr. Fisher touched on it a little bit, where we have these old systems, these old power systems that are currently acting the way things were 20, 30 years ago, but they haven't adapted to new power, which is the new systems, adding in AI or adding in electronic medical records. And so academics is the worst. I joke with my friends who are not in medicine that medicine and innovation in medicine is 50 years ahead of some technology. But the problem is they don't incorporate in the technology, so we can't actually execute on this amazing medical innovation that we have, because the way of things being done, the systems are based in this old power structure. So if we want to make real changes, we need to be thinking, how can we take the old power, the people who are currently in positions of power, the systems that exist, that many of these healthcare systems were actually built before women were even in the medical workforce. I mean, think about it. There's no paid family leave. There's no opportunities for pumping. When I gave birth to my daughter, it was like I was the first person to ever give birth as a physician in the entire history of medicine. I mean, it was really, I was a fellow, and my program director was like, what do we do? And I was like, well, I deliver a baby, and I will take a couple of months off to make sure that, my baby is healthy. And I still didn't take my full maternity leave because there wasn't a maternity leave. So I think we need to think about these old power structures that exist, and how can we bring them into the current day? How can we get stakeholders to understand, okay, well, this is how things were done. This is what is the reality of 2025. How do we take this new power and get the old power to understand that we can integrate and we can innovate? But the problem is, a lot of it is, this is how it's always been, this is how it's always going to be. So we need to, exactly as Dr. Fisher said, we need to be talking about how do we innovate and implement these new structures. The problem is, some of the people in old power are benefiting quite a bit from the structures that have been put in place, and they're not thinking about moral leadership. They're thinking about, how does this benefit me? And these changes, it's a scarcity mindset, which is really, I think, a dangerous way to practice medicine. So we need to start thinking about marrying old power and new power, and creating new systems that think about what has worked and what's working now, and how can we skate to where the puck is 20 years from now, as opposed to thinking about what we did 20 years ago.
So I'm going to thank all the panelists, but I'm going to start with just one positive note. I don't know how many people noticed that the measles rates in Chicago, vaccination rates, went up by 3%. Now, I'm going to speculate. We can clap. That's a good thing. Great news. We could speculate that maybe it was because of all of the attention to the measles outbreaks in the migrant housing situation. But either way, I'll take that as a win. I also want to take as a win the incredible conversations we've had today. We've heard a number of things about how we can improve care. Site-neutral reimbursement was one thing, so without using the fancy words. We also talked about identifying those problems that we can really solve. A little bit about moral leadership. We have, I think, a slight difference of opinion about where we're at the breaking point. Some believe, based on the data, that we are at this incredible breaking point, and what we're missing by not solving is lives. Look, we're out of battery power. It's perfect. I get to have all the control now. Thank you. So it really just some incredible inspirational comments. I think the other thing I will mention, we talked a lot about misinformation, and Dr. Bobby has above his garage, if I'm not mistaken, a place that he tries to be a broadcaster of correct information, in fact, and I'm seeing it more and more in physicians also stepping out of their clinical roles into policy roles, into communication roles, into elected leadership roles. And so I think the more that we can move our science-trained, science-informed, and expert counsel into the reshape, the revolution that's going to transform healthcare, the truth is we will get there 5 years from now, hopefully with a little bit less pain along the way. So if we can thank all of our incredible speakers, and thank you everybody for taking time today to participate.
Thank you. And yeah, I wrote things down because otherwise I don't keep myself on track. I can just go off and I just want to close out to today's program to encourage us to be hopeful, because I know we talked about a lot of problems, but there were a lot of solutions in there as well. So it's really critical that, especially as we end a really tough year, that we look to next year as an opportunity to turn the page. I want to thank Lynn and Dave and Dr. Bobby, Dr. Fisher, and Dr. Jane for their incredible insights. Each of them wear multi-hyphenate hats, both physicians and non-physicians up here, and they all have contributed to my personal growth in many ways, because I've known many of them, or some of them are new to me. I hope all of you are taking a lot from them, and if they're willing, because I know we're right at time, hopefully can keep in touch with you. I also want to point out that The Coming Healthcare Revolution, written by David Johnson, is a great stocking stuffer or like a Hanukkah gift, I don't know, something like that for your healthcare wonk in your family or friend. So feel free to check that out on the Amazon Digital. And I also want to close out this year and say thank you to our members that are in this room that contribute to our platform, and to the many partners and folks that attend our events, that contribute to both our events and our community initiatives. We work with a lot of nonprofits and underrepresented entrepreneurs in the health space to try to actually practice what we preach in these rooms. I know sometimes it feels like we're in this bubble and this hierarchy here, but we do try to connect the dots, and I personally take interest in that. So thank you for having these conversations. I know that each of you walk away from all of these going out to do more, and that is where the action happens. I also want to give a shout out to my colleagues, Caleb, who was in the lobby, who welcomed you, my colleague Erica, who's been navigating to make sure we're capturing this video, and Topher, who's been running sound, and will also be publishing our HC3 podcast in about a week or so. So if you really enjoyed this, want to rehear it, it will be available to you. You can also reshare it with your network and friends. And after that, I also welcome you to grab a few snacks on your way out. And I just want to wish you all a very warm and healthy and happy holiday season. And thank you for closing out this year with us at HC3. So have a wonderful day.